Welcome to this explainer. We're about to break down two of the most critical, most powerful drug classes you'll ever use. These are the agents that let you take control of physiology in a heartbeat, but man, they also demand some serious respect. So let's get right into it.
Okay, let's kick things off with a scenario that gets your adrenaline pumping, for sure. A hypertensive emergency. This isn't just a scary number on the screen. That number means organs are taking a hit right now, and it's on you to intervene, and you've got to do it with control and precision.
So here's our game plan. We'll start with the big picture. Then we're going to master the agents that control blood pressure. From there, we'll get into the art of the perfect block with local anesthetics, face the realities of what to do when things go wrong with toxicity, and then we'll wrap it all up with the absolute must-know takeaways for your next case. Let's do this.
All right, first up, let's talk about controlling systemic pressure. This is all about grabbing the reins of physiology when it counts the most.
At their core, all these drugs basically do one thing. They chill out the smooth muscle in blood vessels. But here's where it gets really interesting, because the power's in the details. Are we trying to hit the arteries to drop the resistance the heart is pumping against, the afterload? Or are we targeting the veins to reduce how much blood is coming back to the heart, the preload? That's the key question, and the answer decides which drug we reach for.
This slide gives us a perfect head-to-head comparison. Think of sodium nitroprusside as your big hammer. It hits both arteries and veins, dropping both preload and afterload. It's powerful. Nitroglycerin, on the other hand, is a bit more of a specialist. It mostly works on the veins, making it your go-to when you really need to reduce preload, like in a patient with heart failure. It just takes that workload right off the heart.
But, and this is a huge but, with all of nitroprusside's power comes a very dark side you have to constantly keep in the back of your mind, the risk of cyanide toxicity.
And this slide just lays out that dangerous domino effect perfectly. It all starts with nitroprusside interacting with red blood cells, which frees up cyanide ions. Now, pay close attention to step 3, tachyphylaxis. This is when you notice you have to keep cranking up the infusion rate to get the same blood pressure. That isn't just the drug wearing off. That is a massive, flashing red light. It's your earliest clinical warning that you're heading towards cyanide poisoning, way before that catastrophic metabolic acidosis and cardiovascular collapse shows up.
The big takeaway here is that we've got a whole toolkit, and each tool has its purpose. You've got Hydralazine, a direct-acting arteriolar dilator that's great for afterload reduction, but you got to be ready for that reflex tachycardia. Then you have something really unique like Fenoldopam, a D1 agonist that not only drops the pressure, but also helps protect the kidneys. And of course, you've got your workhorses like Nicardipine, which are fantastic arterial dilators.
All right, so we've covered the big guns that control the entire system. Now let's switch gears and zoom way in. Let's talk about how we achieve incredibly precise, targeted control with local anesthetics.
This is really where the magic happens. Think of these drugs like tiny little spies. They have a lipid-soluble, non-ionized form that can sneak across the nerve cell membrane. But once inside, they change. They become ionized, and in that form, they act like a plug. They physically block the voltage-gated sodium channel from the inside, so sodium can't rush in. No sodium influx means no action potential. The nerve impulse just stops dead in its tracks. It's literally like cutting the power cord to that nerve.
Okay, this is Anesthesia 101, but for a really good reason. It's absolutely fundamental. You have to know if you're dealing with an ester or an amide because it tells you the drug's entire life story in the body. Esters, they get broken down right there in the plasma, and one of their byproducts, PABA, is a pretty well-known allergen. Amides, on the other hand, they're processed by the liver, which means the chance of a true allergic reaction is way, way lower.
This table right here, this is your clinical cheat sheet. Seriously, you want to know how powerful a drug is? Look at its lipid solubility. The more lipid soluble, the more easily it gets into that nerve and the more potent it is. Need to know how fast it'll work? Check the pKa. The closer it is to our body's pH, the more non-ionized drug is available to cross the membrane and the faster your block will set up. And how long will it last? That comes down to protein binding and lipid solubility. The more it binds, the longer it sticks around.
Now this is one of the most important safety concepts in all of regional anesthesia. Location, location, location. The risk of your local anesthetic going systemic is all about how vascular the spot you're injecting is. Obviously, an accidental IV injection is the worst-case scenario, but look how high intercostal blocks are in this list. That area is just swimming in blood vessels, which means way faster uptake and a much higher risk of toxicity than, say, a sciatic block, where absorption is way slower.
So, we've talked about how to use these powerful tools. But now we have to talk about what happens when things go sideways. Because with this kind of power comes the potential for really serious complications, and you have to be ready.
And this is it. This is the one we all worry about: local anesthetic systemic toxicity, or LAST. This is what happens when too much local anesthetic hits the bloodstream and causes a truly devastating cascade of events.
Your central nervous system is incredibly sensitive to these drugs, and thankfully, it gives us the first clues that something is wrong. So if your patient, right after an injection, says they have ringing in their ears, or their lips feel numb, or they have a weird metallic taste, you must stop everything. These are not just weird side effects. These are the classic textbook warning signs that come right before seizures and cardiovascular collapse.
And this number right here, this really puts it into perspective. It quantifies that terrifying progression. The CNS symptoms are your last call, your last chance to intervene before things get so much worse. Because once a patient starts seizing, you are getting dangerously close to the drug levels that cause profound heart depression, crazy arrhythmias, and a full-blown code.
Bupivacaine is the poster child for cardiotoxicity. And you need to know why. It's because it latches onto cardiac sodium channels incredibly tightly, and it lets go very, very slowly. So once it grabs on, it's not letting go. This leads to these awful, hard-to-treat arrhythmias and makes resuscitation a massive uphill battle.
Okay, these are the 4 critical, life-saving steps. This is not something you look up in the moment. You need to have this protocol burned into your brain. 1. Stop injecting and yell for help and the lipid rescue kit. 2. Manage the airway, get them on 100% oxygen. 3. Get those seizures under control with benzos. And 4. The crucial step, administer the antidote, 20% lipid emulsion. This lipid sink literally pulls that lipid-soluble local anesthetic out of the heart and brain tissue, reversing the toxicity. Whew! Okay, we have covered a ton of ground, so let's bring it all home and boil it down to the absolute most essential points you need for your practice.
This chart really puts the stakes into perspective, doesn't it? Both of these drug classes are high benefit, no question, but their risks have a different flavor. Cyanide toxicity is awful, but it's often a slower burn, something you can see coming. LAST, on the other hand, can be a sudden, out-of-nowhere catastrophe. And what that really highlights is that your single most important tool, no matter what drug you're giving, is just constant, relentless vigilance.
Look, if you only remember 5 things from this whole discussion, make it these 5. 1. Always continue your patient's beta blockers. 2. Tachyphylaxis with Nitroprusside is cyanide toxicity until you prove it's not. 3. Respect bupivacaine. It is cardiotoxic. 4. Know the difference between esters and amides. And 5, before you even think about doing a block, know exactly where that last rescue kit is. And that's our deep dive. These drugs are true power tools. They let us manage physiology in ways that are just incredible. But with that power comes a huge responsibility. Your patient's safety really comes down to your knowledge, your preparation, and your vigilance. So I'll leave you with this question. What's the one safety check you will never, ever skip?